I'm Alex Menes, CEO of Motilent.
Hi, I'm Seb. I'm the founder of IBDrelief.
So Seb, we have not just known each other, but worked on and off together now for nearly a decade. And I think that with the news that, IBDrelief and Motilent are now one organisation, and outward looking, Motilent is a technology company that's obsessed with the minutiae around how we measure inflammatory bowel disease with imaging technologies. Very technical. You are down the other end of the universe, it feels. Very patient-centric. You yourself are a huge advocate of patients, but you've also been doing a lot with IBDrelief. And I think there's a degree of how are these two guys working together. So I think what might be helpful is if you yourself could talk about how did you get to where we are today, which is this lovely room that's well lit.
So I've personally had ulcerative colitis for coming up to 17 years now. I had my own struggles with the disease for the first few years. I learnt myself that the more I kind of started to understand about the condition and learn about the condition, the better it was helping me improve my quality of life. So that was what inspired me to set up IBDrelief, is to try and see how could we improve the education and knowledge of patients.
I think that the bit that I got stuck at massively when I was making tech, as in we worked for this NIHR-backed grant that was looking at how, and if we have to be specific, we could look at the peristalsis of the bowel to predict how well people were going to respond to some therapy that cost $10,000, $20,000, $30,000 a year. And we were compelled by the NIHR to say, ask patients how they felt about this. And it's not like I wrote it off, but every patient I asked was a bit like, well, get on with it then already. Stop telling me about it and do it. It's a hospital test. Just give me the best hospital test. And I think that in some ways I was completely shut out of being able to engage with patients. But as I've kind of gone around in circles for the last few years developing the technology, the piece that seems to be very real is things aren't getting better for patients. And I'd say we've been stuck for 10 years now at least. And then we started speaking a bit more, and it turned out from you that, and maybe I'm getting this wrong, but many patients don't even know that biologics are an option, let alone some of the advanced therapies, and I was off in the wrong place. So can you just summarise what the situation is for most people that get a new IBD diagnosis? And is it when they get a diagnosis it gets easier, or does the problem really begin there? I mean, what's the journey? Because I think it's not clear.
So from my own experience and from talking to lots of different patients, at the moment getting diagnosed is still a big challenge. People are being fobbed off by GPs or hospitals or A&E. So I think there's a piece still in terms of how do we get people diagnosed better? Is there a clearer test or a clearer pathway? And I think it's sort of a mix of lots of different things. Once someone's diagnosed, then it's about getting them on the right treatment. And compared to when I was diagnosed 17 years ago, there's a lot more treatments available, which is a really positive thing. But like you said, people still aren't necessarily aware of what treatments they could be on. My impression is a lot of that is driven by cost. So a lot of the newer biologics and small molecules are very expensive. So rightly so, the NHS would want to put them on some of the cheaper treatments and see if they work. And there's still this big challenge around, we don't know what medication is going to work anyway. It's still a bit of a blind, let's try this, see if it works. If it doesn't work, we'll try another one. It'd be nice in the future when we can get to the point where it's like, okay, you've been diagnosed, here's some kind of test or something that would then say, this one's the one that's going to be for you. And we're still not at that place.
Do you think patients don't know essentially how to push for themselves when it comes to getting the right medication? I mean, at last year's Echo, there's this big hoo-ha made about the profile trial and how top-down therapy was absolutely the best way. And that was proven years ago that it was the case, that it still just doesn't seem to be what people are doing. So is it a case of a patient needs to ask for it and get it, or is it just that hospitals are just ill-equipped to make anything happen on this front?
I think as a society, we've been brought up, taught that if there's something wrong with you, then you go to a medical professional, they will diagnose you and they will put you on the right treatment. There's not like, that's very broadly speaking, but there's people don't necessarily know much about the condition or how to treat it or what's gonna help them. So they're relying on the healthcare professional to make that best judgment for them. What I've sort of learned and experienced is it is important to start to understand the different options for you, because ultimately you care the most about your care than anyone else. And the people making decisions about you, they've got so many different cases under so much pressure. Not that they're going to make the wrong choice for you, but that they might not have thought about something, or they might not have considered some options. So the better informed you are as a patient, then the more likely, in theory, you're going to sort of get the care that's going to be right for you.
And presumably this is where you got into things with IBDrelief, the website, right? And I think that the website is obviously how I discovered you. It's like, well, all this awesome stuff is just written up plainly and understandably. For my, I haven't got IBD, but it was very helpful to know like what people are going through. But there's only so much you can do just by creating materials. And I think that one thing that I'm paraphrasing here, but I've heard a lot of patients say is, well, they're coping and they seem to work out really clever ways of getting on top of their disease. Like one project that like Motilent's been very ensconced in now is around patient-reported outcomes in fibrostenotic disease, and amazing work has been done by researchers that are looking at ways of getting symptoms to correlate with the actual disease pathology. And what's really, I wouldn't say undermined this work, but made it clear how challenging it is that a person with obstructive disease gets real smart at what they can and can't eat. And they just seem to go around all the foodstuffs that give them any kind of obstructive symptoms. So of course they don't register high enough on the patient-reported outcome tool. And then they can't qualify for trials, and the drugs don't suddenly work on them, and everything kind of goes away. And I think that the really big concern for me was that patient adaptation to their disease throws off a lot of things and potentially de-escalates the severity of the disease, which could stop them. Is that something that you've seen, I think, with your work through IBDrelief, but especially as you've, what I'd say, precipitated a product out of your website in the form of IBD Mate, which you can tell us about in a second, but that truly characterising understanding what a patient does and how they really are, not their new normal, I think is a key thing. And I think that's been throwing off all of my work for several years now. But where do you stand on that? Is it real? And do you think that's one of the things that actually is causing problems for us, recognising the disease?
Yes, I think in my experience, there's so many sort of subjective measures of how someone is. And like you said, people want to feel better. People want to kind of get on with their lives. People end up putting up with a lot of different stuff. So I think when people are reporting like how they are, how they're feeling, then it can get skewed because they're trying to get better. Again, when you're sort of asking people like how are you doing, how are you feeling, are you better or worse or whatever, again, they're all kind of subjective things based on how that individual is at the time. If you've had a period where you've been going to the toilet, like in my worst, I was going to the toilet 30, 40 times a day. If I was then going 10 times a day, I'm like, oh, I'm better today. But I'm still not good, or I'm still not where I probably should be. And I think there's a really important bit around how do we start to quantify some of these things and use clearer measures to indicate where someone is with the disease, and allow people to realise what is possible as well. That's something I've seen a lot with patients where they're kind of like, well, I'm doing okay. And you're like, okay, you're doing okay, but you're still going to the toilet a lot. You've still got urgency. You're still maybe not being able to work. You're still not being able to see your friends or whatever. But that's become their new normal. And they're like, well, that's okay. And it's like, well, actually, what if you could be doing this? And I've seen lots of people that then maybe switched to a better treatment. And then they're like, oh, wow, I wish I'd been like, or wish I'd switched this treatment a long time ago, or made that change sooner.
If you were to guess, out of, say, 10 patients, what percentage of those do you think are coping but could be switched to something better? And this is no criticism of the healthcare system. I think that if there was one country that was knocking it out the park with IBD, we'd know about them and we'd all copy it. I think the fact that this is uncorrelated with the country's GDP, I think, says that it's a problem. But so I'm not having a go at the NHS here, that's for sure. But if out of 10 patients, how many would you say that could be like modified upwards, or at least?
I don't know. Like, as my hunch would be like probably 6, 7 out of 10. I think are probably not living as optimally as they could be. There's always, like, at the moment, like, I'm feeling the best I've done in most of my life, but there's still little bits where I'm like, oh, okay, well, I'll just deal with that later, or that's so that I think. Yeah, I think there's a lot of people that aren't in as good place as they could be.
IBD Mate is sort of your magnum opus, I'd say, so far in terms of how you proactively engage with patients. Can you just summarise what it is, how it works? And the thing that I have seen is like the results from the surveys at Addenbrooke, for example, which are impressive, but give us a summary so far.
So to take a step back, so IBDrelief.com was the website that we set up originally. That was intended to be an information resource for people to find things online about their condition. And I was quite keen to look at how can we start to share people's stories or things outside of just like living with IBD. There's a big kind of medical component, but there's a big bit of like, how do you live with this thing? How do you find the nearest toilet? How do you deal with stuff day to day? And I felt that, I had learned a lot from other people's stories and people talking about stuff online. So it was like, is there a way that we could kind of capture that in kind of website? And that was kind of where IBDrelief.com sort of started. But as I started to meet more patients and start to understand more about the healthcare system, everything always seemed to come back to patients don't understand enough about their condition. They don't understand enough about what is, where they could go with it, how well they could be. And there's the saying of you don't know what you don't know. So with something like a website, you're relying on that person to search for like, oh, okay, I've got this problem, I'm going to go and search for that solution. Whilst a lot of people that are kind of living unknowing that they could maybe make a change or could do something better. So in my head, it was like, if we could sort of teach, if you're in an ideal world, you're diagnosed, you're then kind of put into some kind of education program. It's like, okay, you're diagnosed, here's your treatments, but here is your education. Here's your, like, this is how you're going to live with this thing. Here's the handbook, the manual, whatever you want to call it. So that was kind of where IBD Mate was born. It was like, the website was good for people that knew what they're looking for, but there's a lot of people who didn't know what they possibly needed to know. So IBD Mate was born to try and fill that gap, to try and offer a solution that would, in a slightly more formal way, kind of educate people through a journey if they wanted to. So IBD Mate right now is an online education resource for patients with inflammatory bowel disease. We filmed lots and lots of videos with healthcare professionals and patients to tell kind of stories about all the different aspects. It might be, what is IBD, what treatments are available, what's the procedure, or it might be like how to deal with school or how to deal with your parents or whatever. So huge amount of like knowledge information there. We've been testing that initially with the paediatric team at Addenbrooke in Cambridge, and they now use it as part of their standard of care. So every patient is given access to IBD Mate, and we also have the ability to like prescribe videos. So they go to clinic and they're then prescribed the videos to, so they know exactly what they need to know at that particular time. So it's like, okay, you're going to start this treatment, understand about that treatment. You're going to go for a blood test. This is what a blood test involved, rather than having to worry about everything, because it can be quite overwhelming about all the things that you could know.
And it sounds like the kind of thing that should be done anyway by the IBD nurse, the gastroenterologist, part of the team. There should be like a piece of paper done is clearly working, but why isn't it already done, and why is it so successful at the moment in anorexia?
I think so. Coming like into the healthcare industry from outside, other than like as a patient, it's always sort of surprised me as to like there's a lot of what seems like fairly obvious, easy things to do that just aren't being done. But a lot of time I just don't think the healthcare system has the time to sort of think about some of these problems or challenges. In terms of the education, like currently in like a more typical service, the education tends to fall on the hands of the healthcare professionals, which they do a great job of that. However, they just don't have the time to see patients. You're kind of crammed into these 5-10 minute appointments. I look at our like what is ulcerative colitis course, and that's like half an hour's worth of videos. Like, how do you compress that into a 10-minute consultation alongside starting a treatment and going for an MRI scan or going for a blood test or whatever it's going to be? So time is so limited for these healthcare professionals. You also have variations in how someone might get something across. Like, you might be a really good clinician at choosing the right treatment or doing an endoscopy or something, but are you the best person at explaining something? That's not always the case, and that's not part of like medical training. I think there's also depends on like where someone is, their kind of frame of mind, that like we all do our jobs and we're all like, we might have had a late night or not feeling great or whatever it might be. You're then not going to maybe deliver that education in the same kind of way. So by capturing it in videos, making sure that we've got it in the kind of the best light, then it kind of gives that consistency. We've also heard a lot, and I've experienced this myself as well, like patients, when you're sat in these appointments, you're probably not concentrating, your head's not in the right space to receive some of this information. So having the opportunity to go back later, watch it again, share it with friends or family or whatever it is, then that's like can really sort of help those patients on that journey. There's also something which we're exploring more now is around like language barriers and like how, again, like if you're in an appointment and you don't, like English isn't your first language and stuff like that, then trying to understand this medical information is really hard. So again, can these educational resources help support those people?
And I appreciate the irony of discussing this as we record like an hour plus of footage, but I feel like people struggle with long form content now. And even if you were to have an hour long clinic slot, it'd be tough to get through that very information dense material. And
it's really overwhelming. And I think I like look back to points in my journey, and then I've sort of seen similar cases or variations of it when I've had the opportunity to meet other patients. Like when I was diagnosed, I was really sick. I spent 9 days in hospital. I wasn't like 100% with it some of the times because I was so dehydrated and malnourished and whatever. So I can't remember a lot of stuff that was said to me. So it's hard to digest that information at those times.
The other piece that I'm fascinated by is how much less difficulty I've had working in paediatric centres than in purely adult centres. No one wants to do things that aren't going to benefit a child. You're not going to have a few bonus scopes just because. You really want to do exactly what's right to get that kid better again as quickly as possible back to school and well. And I think that the attitude around paediatric IBD is just that little bit more notched up towards doing the best thing as quickly as humanly possible to get this going well. I think that's my take on it. Certainly we've found the best reception to our technology has always been from the paediatric centres because we're reducing scan times, so they're not wriggling around and messing up their MRIs, and very pro anything that can remove injections and all that kind of stuff that kids don't like. And generally, I don't want to go off on a complete tangent here, but there's this whole notion about kids have more small bowel Crohn's than colonic Crohn's. The reason is we use imaging more for kids and we use scope more for adults. So we pick up more stuff from the scope in the colon than we ever see in the small bowel of adults, and it's kind of like we've just got a different almost disease in pediatrics. It doesn't change the fact that drugs go to adults first and then to kids, and we do treat, I think pharmacologically at least, a lot of the kids like mini adults. But do you think you've had more success targeting the pediatric community and I suppose their parents as well than you might have otherwise experienced in adults, or have you just not got to the adults yet?
It was kind of a little bit by accident, if I'm honest.
All the best things are, yeah, that's the way.
We did a project with KICRA, the children's IBD charity, and got introduced to the team at Addenbrooke's. And I was explaining my idea of IBD Mate and what I wanted to do, and the lead there, Rob Herschel, was like, wow, this sounds great, like would love to support you on that. So like really fortunate to have met him and worked with his team, and they've been incredibly supportive and instrumental to helping us get IBD Mate to where it is. However, so that was kind of like an accident, but in hindsight now it's had so many benefits, because I think as a team, the pediatric teams, when they're still stretched and have a really challenging job, but the time or the number of team members per patient is 10 times more. So the team at Addenbrooke's, they look after about 400 children, whilst the adult team at Addenbrooke's look after about 4,000 people. But in terms of the team size, they're relatively similar. So there's just a lot more time available in comparison to adult care. There is also the parents. So the parents are, in my experience, like more motivated than ever, and I understand that as a parent myself as well. Like they're more motivated to learn and help and understand than like I ever was. I mean, it took me 5 years to even sort of take my head out of the sand and kind of start looking into like how I can actually make myself feel better. I think working with the parents has been really beneficial. It's also been really insightful to sort of see how the young people live with it and deal with it, and then also how it affects the whole family and people beyond it as well. And we've just learnt so much from these young people, and how when people talk about like the literacy of people generally is like a 12-year-old or a 9-year-old or whatever. So actually, if we're designing education materials for these young people, then that's going to be beneficial for the whole general public as well.
Yeah, I think one of the big reasons that I think has brought us together more in recent years is I think that we are entering, maybe I'm getting too excited, but I think we're entering an era of IBD that is actually looking fairly interesting for patient outcomes. Like, I'm just blown away how technology can creep up on you sometimes, but at Motilent, we've been working a lot with intestinal ultrasound, and that's been around for 30 plus years. There's nothing new there, but the big difference is that now you can get ultrasound probes that plug into your phone and give near diagnostic quality. And we are not far off a patient. They don't need to do a new diagnosis on themselves, but if you know that you've got ileal disease in a child, there's no good reason the parent can't scan that bit and get the data back to a radiologist to have a look. We have got video capsule endoscopy that can look at the entire small bowel, and we've got AI that can read it for you. There is a real opportunity here for patients to, I wouldn't trivialize the complexity of care. They can't just take control of their care and do it all themselves. But the ability for them to collect important telemetry data on the mucosa, the transmural changes across the bowel wall, heart rate variability, all this stuff, and transmit that back to a good physician remotely from the center, I think that technically that is possible right now. What's not possible is the healthcare system to interface with that. And I don't think the patients are yet trained up enough or even know it exists. I mean, if they don't know about the latest drugs, they're not going to know about the latest advancements in transmural healing. But I think that there's a void of education that I think we need to bridge. And I think, if anything, what we're looking to do now is going to be, how do we close that gap around, there's part of the art of the possible. But I think we need to start really finding out ways of how do we spot the patients. And I think, going back to the kids, the children grow up, and I think they tend to drag their care along with them. And if a child is used to really high quality pediatric care, and then they turn, is it 16 or 16, and get dumped into a clinic that's overrunning, they don't get any testing, they're going backwards on their therapies or whatever, they're going to be like, what the hell's going on? And it's going to drive them, I think, to engage with resources, and especially the work that you've done historically. I think that's a big piece. But I guess I'm a technologist at heart, and all I want to do is help patients get better. I'm here to kind of solve complex technical problems with the business, I think, and I don't really have the right to speak about trying to help patients directly. I think that, if anything, that's more what you do. But from your side, how big is certainly the gap around upgrading the tech piece? And do you think it's possible? And how would you potentially begin rolling this out to patients over the next 10 years, say? Let's not make this a tomorrow thing.
Well, there's such a need for improving the technology that's like being used in IBD and in healthcare in general. I think, again, it's kind of surprised me, having a long-term condition, as to sort of like how far away we are from what probably should be happening. And that's not to devalue the work that's going on, but it's like, I step in my car, and my car knows when its next service is, and knows what temperature things, and knows what the tire pressures are. Like, right now, I have no idea what's going on in my body. Like, I've learned myself how to sort of read my own symptoms, but I've got no idea what my inflammation levels are. I've no idea what my fecal calprotectin level is. Like, standard of care at the moment is you probably have a fecal cal once a year, if that. You have a blood test maybe once a year. There's such like small time snips of data. Why are we not using at-home fecal calprotectin if we can start to use at-home imaging like ultrasound? I mean, that like is like super cool. I think there's some challenges around, are people gonna, the worried kind of whale start scanning themselves?
Rolling around with ultrasound probes, scanning everything.
Like every few hours, like scanning myself and see if I've got better. So again, that's where the education piece of like, how do you use this appropriately? But yeah, the visibility is just so poor right now, and it must be like a really hard job to actually manage people and understand what's going on. So I think that's where like there's some big opportunities, and I think there's some really interesting opportunities then with research and how we sort of take the disease forward as well, because once we start to understand that slightly more, like a lot more kind of stepped approach of like what's going on with someone, then we can like I think it will kind of make us realize things we didn't know. For example, I've got a friend that's got type 1 diabetes and had that since she was a child, and she, I say recently, it's a few years ago now, but had a continuous glucose monitor installed, whatever the right term is for a patient. And she was really surprised, or like worried at first, because she was like, she had been sort of tracking her glucose every couple of hours or something before. Now she could see it going up and down. She's like, oh my God, I'm hypo, or I'm hyper. But just hadn't realized actually it's nowhere near as stable as it was. And again, I think I'd be fascinated to sort of know, like for me, like, does my fecal calprotectin change daily or hourly or whatever? Like, and how does that then potentially correlate to symptoms? Or are there treatments that we thought weren't working that actually were working because we just we weren't looking at the right thing? So I think there's a lot there.
I mean, I love the diabetes analogy that I often throw around, and I'm sure that if you're diagnosed with diabetes now, you're not happy about it, and I'm sure that people with diabetes aren't happy about it because it's a really challenging disease. But if you look at a snapshot of today versus 1970, like the sensor, the patch, the the ability to measure stuff is unbelievable. We're going to get there with artificial pancreas and closed loops. But there's like this real drive from the medtech industry and physicians to kind of knock this problem on the head. And I think that we have just not seen anything that looks like that in IBD. I think at-home fecal count's great, but if you've got small bowel disease, it's not going to shoot up. It varies a lot in healthy people. You need to trend it. And I think it's one part of the puzzle. Like the other bit is what's your mucosal health. And just to kind of elaborate a bit, I think that we are just not even having the right conversations in a lot of what we look at IBD. If you imagine someone's ticking along through time, we have inflammation going up this way, and they come out of a new diagnosis or out of remission, there's a flare, and then we try and knock them out of that flare, and some of them do well. Most never return back to true baseline that well. But every single drug that we have access to is for moderate to severe disease. Mild disease isn't even described. We don't even have ways of measuring it. And what you really want to be asking, especially if I had IBD, is where the hell's my treatment for mild disease? Like, don't let it become a problem. If you're a diabetic and you had your foot amputated, and you're like, well, we got on top of that foot bit quickly, so you're not going to get a necrotic toe now. You'd be like, what the hell? Like, get my insulin under control and don't let that happen in the first place. And this closing the door after the horse has bolted mentality in IBD, I think, is one of the biggest issues that the community, both in research, clinical practice, and obviously from the patient side, we need to get on top of, because we shouldn't be having early surgery. We shouldn't be going for surgery in the first place. We have to, because that's what we've got. But until we can actually work out what we're doing with mild disease and spot these flares coming in, which I'm convinced that it is not beyond the ingenuity of the human spirit to do that now, I don't think we're going to see the type of changes that we need. And it really bothers me that there is not a little bit more doing about it, despite lots of investment funding to the place. And if we look at the pharmaceutical sector, I believe at the moment inflammation is the single biggest market segment at the moment. So there's not a lack of money coming in here, but why that isn't turning into better outcomes for patients and hasn't really seen an improvement in 10 years is distressing to me, and I presume to you. And I hope that potentially with the two angles that we're tackling, we can actually start putting some of the pieces together in small parts of the problem. So with ultrasound, for example, I don't see a world where everyone's just ultrasounding themselves all the time. But when you've had a flare, you've got the lesion that's bad. Ultrasound's a great tool for watching a bad thing get better. So the training ask then isn't go and spot disease. It's here is the disease and we expect it to go in this direction. And it radically simplifies the problem when you can frame it like that. Similarly with capsule, this is the ingestible endoscopy capture device. If you stick that in someone, the big fear it gets wedged, stuck, and then you'd go for surgery and have it removed. And that kind of puts the yips on a lot of people. And I think with modern protocols, that's very rare now. But using capsule in someone that has got a very active disease is a bit of a no-no. It's too dangerous and it's just not worth the hassle until some brave people go out there and do the trials. And as a separate topic, the colon cam for colon cancer screening was spectacularly effective and not that much inferior to regular endoscopy, so good for at-home use. Let's watch this space. But the capsule's better suited not for the active bit, but for the remission bit, and that can give you that very subtle mucosal change that would complement fecal cal and symptoms to kind of look at the remission part as opposed to the active part. And I think the thing that we've got to really get good at here is actually kind of lining these things up, matching it with the people that need it the most. That is the patients, but in the short term, it's going to be backlogs and technical challenges at hospitals to doing this. And we do need patients to know that A, it exists, and if it's right for them, they should be asking for it. Just like the diabetics are asking for the patch and the pump now. They see this online and they're like, well, why the hell am I injecting myself with this stuff? And why haven't I got access to this? And that has driven the change. What would you like to see happening in the next year? So you're sort of under the Motilent umbrella now, but as far as I'm concerned, you've got to just keep doing your own thing. Like, where are you going to be focusing over the next 12 months?
So my own focus with Motilent support would be looking at introducing IBD Mate to more centres. So we're about to launch the adult version of IBD Mate with St Mark's, and then we've got other centres that are going to be following that up very quickly. So my main focus is going to be about how do we get this in the hands of more patients, because every time we've given it to a patient, we've got really positive feedback from it, get positive feedback from the teams. I almost feel like it's wrong that patients aren't having access to this. So that's the main focus. There's then a piece around how do we kind of validate it. So how do we make sure, like, I'm very confident in what it can do and what's happening with it. But it's like, how do we demonstrate that, oh, okay, we give this to a patient and it improves whatever that might be. It might be it improves conversations in an appointment. It might be improves medication adherence. It might be reduces anxiety about going for a procedure, or it improves quality of life, whatever that might be. And I think that's where it's always been a challenge, is there's lots and lots of places it could have an impact. Some are very quick to see, some are much more long-term to see. So how you kind of untangle that and demonstrate it, which I think is where IBD is a real challenge. It's such a complex disease, and there's so many different kind of factors at play, like psychological, environmental, et cetera. It's really hard to sort of pin things down into one thing. Like, there's no real like proper robust trials on diet, because how the hell do you like clearly control diet in a normal randomized controlled trial? So so getting IBD made out to more centres, validating it to sort of see how it performs, and then learning from that and learning how do we make it better, how do we best educate patients, and I know this from experience as well, like, just because you give these tools to someone, are they actually going to use it? Is it the right time for them? Again, there's so many different things. We need to sort of learn from that as well.